Gallego. I currently serve as the Gravity Project Program Manager. I'm here today to present to you on this project, and we're excited to share on our work to develop data standards for social determinants of health. Here is a quick agenda for my talk today. I will provide an overview on the why and the what of our work, ending with a summary of our accomplishments to date and how you can engage in this important initiative. So let me start by acknowledging why social determinants of health, or SDOH, are important. For those not familiar with the term SDOH, it refers to the conditions in which we are born and live that affect our overall health and quality of life. We know that over 50% of our overall health is driven by socioeconomic factors and the physical environment. Today, we are seeing a growing interest in health industry stakeholders around addressing SDOH in clinical settings. We know unmet social needs negatively impact health outcomes, and the global COVID pandemic shines a big light on these as we are hearing more and more about the increasing health disparities as a result of unmet social needs. So, for example, food insecurity correlates to higher levels of diabetes, hypertension, and heart failure. Housing instability factors into lower treatment adherence, and transportation barriers result in missed appointments, delayed care, and lower medication compliance. Even with all this growing evidence, clinical systems have not been able to consistently and effectively address these needs because of existing challenges around SDOH capture and exchange. And these include areas around consent management, standardization of SDOH data collection and storage, data sharing between ecosystem parties, access and comfort with digital solutions, individuals' concerns about information collection and sharing, the social sector's capacity to receive and address a growing number of referrals, and the unnecessary medicalization of social determinants of health. In 2018, the Social Interventions Research and Evaluation Network, otherwise known as SIREN, out of the University of California in San Francisco, conducted a study to find out more about these challenges in integrating SDOH data. And what they found is that existing medical coding vocabularies are poorly equipped to capture SDOH data and related activities. So enter the Gravity Project. The goal of the Gravity Project is to develop consensus-driven data standards to support the use and exchange of SDOH data within the healthcare sectors and between the healthcare sector and other sectors. We are focused on developing data standards for the multiple social determinants of health domains listed here, which include food insecurity, housing instability, and transportation insecurity. The Gravity Project was launched as a public collaborative in May of 2019. Our scope is to develop data and interoperability standards to represent and exchange patient-level SDOH data captured across the 4 clinical activities of screening, diagnosis, goal setting, and intervention. In August of 2019, the Gravity Project officially joined the HL7 FHIR Accelerator Program and just completed its first ballot cycle that I will speak to later on. We do all our work by convening a very large public collaborative of now over 1,500 participants that span entities across the health and human services ecosystem. We welcome anyone to join and participate in our work. We meet bi-weekly, Thursdays, 4 to 5:30, as listed there at the bottom. As a FHIR accelerator, operations are maintained through the generous support of several organizations. Here is a snapshot of our sponsors to date, which do include the Office of the National Coordinator and leading healthcare systems. We describe the work of the Gravity Project as two work streams, the SDOH domain, or terminology, and the technical, or FHIR. Although both work streams function in parallel, they interact in the center in the publication and use of value sets. The Gravity Project was initiated to address the coding gaps identified by health systems. The coding work is critical for this project, but at the same time, we need to support the interoperability of this data across different systems and different system activities. This is where FHIR plays a key role. It supports both the representation of SDOH data, specifically by pointing to these published value sets, and the exchange and sharing of this data across disparate systems using FHIR-based open APIs. So let's do a deeper dive on the terminology workstream. The terminology workstream focuses on defining data concepts for SDOH domains by asking, what concepts need to be documented across the four activities of screening, diagnosis, goal setting, and interventions? After we define the concepts, we ask what codes exist or what new codes need to be developed. And as you see in the visual here on the right-hand side, we look at codes as represented through LOINC, SNOMED CT, ICD, and ICD-10. Here's our very busy roadmap that shows the trajectory for the two active work streams and introduces there at the bottom the new work stream we will kick off later this year, which is focused on pilots. The pilot work stream will support the testing and evaluation of the FHIR implementation guide and reference implementation that we're currently working on. The horizontal green line indicates where we are in the timeline. We completed food insecurity at the end of 2019. Last year, we completed housing instability and homelessness and are close to completing inadequate housing, transportation insecurity, financial insecurity, and demographics. We will start intimate partner violence, social isolation, and stress next month. We also have on our horizon for later this year to work on food deserts and neighborhood safety. And as you see here, at the same time, we're working on our FHIR IG. We completed the ballot that we'll speak of, and we're currently in ballot reconciliation with the goal to publish a FHIR implementation guide by the summer of 2021. Here's a snapshot of the status of where we are within the code submissions and value set publication. So far, food insecurity data elements have been submitted. Only LOINC-coded concepts have been published. The housing domains have also been submitted, but not yet published. We just recently submitted transportation, financial insecurity, and demographics for ICD-10, and we're currently working on the LOINC and SNOMED CT submissions for this quarter. Here is an example of how coded food insecurity data concepts are represented across the four clinical activities. You see LOINC is used to code question-answer sets for screening, as well as for goals that you see there at the bottom. And goals can be incorporated in care plans. SNOMED is used to represent food insecurity observations tied closely with ICD-10 Z codes, as well as for interventions. And ICD-10 is predominantly used to represent diagnoses via the Z code. The ones noted with a star here, TBD, are the ones we're currently still working on and proposed and not finalized. We appreciate that finding all this information on our Confluence site may be challenging. Here's a snapshot of our terminology workstream Confluence page, and the link here at the bottom will take you to this. Here you can find the most up-to-date data sets for each domain I just spoke of. You can also find within each domain what code submissions have been made to date. So you can take a look at that. We're very transparent in our activities. Let's move on to the technical work stream. How we accelerate adoption of nationally recognized standards is by incorporating the standards we use to define the data, in other words, the semantics, into the standards we use for syntax or structure. Basically the standards that are the containers for moving or exposing this data. Each of the coded data concepts across the four activities of screening, diagnosis, goals, and interventions are represented for exchange in the HL7 FHIR specification. So FHIR has its own resources. For example, for capturing, it has a questionnaire response resource to capture screening data. It has an observation and a condition resource. And it also has a goal resource and then resource specific for the interventions and the type, whether it's an order or a service request or a referral. So there's alignment across from the content and from the representation perspective. So this brings us to the scope of the Gravity FHIR IG. The Gravity FHIR IG supports the capture and exchange of multiple social determinants of health domains across those primary activities that I just mentioned. We just balloted the IG as part of the HL7 January 2021 ballot cycle, and we're currently in the process of reconciling the ballot comments for a target publication as a standard for trial use, or STU, by the summer of 2021. The link to the FHIR IG is here at the bottom. The FHIR IG incorporates 6 use cases, as you see here on the left-hand side. The first is the capture of SDOH data as part of the assessment or screening process, the setting of goals based on the health concerns identified from the screening results, the planning and execution of interventions to address the goals, the measurement of outcomes based on those interventions, and finally, the aggregation of data for upstream and downstream use, including population health, risk adjustment, public health, and or research. Across all is the ability for the patient to consent to the sharing of the SDOH-related data. Again, the link to the FHIR IG bill is here at the bottom. So what's next? Over the coming months, we will continue to engage with the National Library of Medicine, or NLM, and registries and other stakeholders to advance the FHIR-based tools needed for the implementation guide. We will continue to incorporate the data definitions as they are developed under the technical workstream. And we have started work on the reference implementation and hope to have it completed for the May 2021 FHIR Connect-a-thon and for use in the upcoming pilot. The FHIR IG team meets weekly, and the meeting information is available on the links listed here. So this brings us to our accomplishments and success factors. Over the past year, we have accomplished so much within the Gravity project, which really is an incredible amount of work, given that we work with such a large group of stakeholders. So here is a snapshot of our accomplishments over the past year. What I want to emphasize here is that all this work is about setting the baseline for advancing the integration of social care and clinical care using data. How we measure success in the next 2 to 5 years is in how this work will be integrated and used across these 6 areas of policy, including the ONC USCDI and the CMS Interoperability rule, how it's incorporated in payment models, in programs, in grants, in practice, and as well as in innovation. So we hope that our work, and we're seeing this already, and I'll give you some examples, that are informing other initiatives in other areas in the ecosystem. So case in point is policy integration. So we say one of our success factors will be the inclusion of the SDOH data in the ONC US Core for Data Interoperability. The Gravity project made a formal submission to ONC on October 23rd of 2020. On November 4th, ONC categorized the Gravity submission as a level 2, as shown in the right-hand image and available through the link here at the bottom. Last month, ONC did publish the draft version and did not include the SDOH submission or Gravity submission for version 2. However, we continue to work with ONC and the USC CDI task force to inform what will be included in the final version proposed for after April or summer of this year, as well as then what will be included for version 3 or proposed for version 3. Last month, CMS published guidance for states on opportunities under Medicaid and CHIP to address social determinants of health. This guidance clarifies how states can use federal funding to support the implementation of a technical infrastructure that integrates health and human service programs. The letter directly encourages states to review and incorporate SDOH standards as published in the ONC ISA and developed by the Gravity Project. The link there is at the bottom. So lastly, let me end on how you can engage in this work. So for one, we would welcome you to join the Gravity Project. The link is there. Again, it's free to join, even though we are an HL7 FHIR accelerator. There is no cost associated to participate in our activities. We only have to be an HL7 member if you want to vote or comment on the ballot. We have two work groups based on our Workstreams. So our terminology workstream is the public collaborative that meets bi-weekly on Thursdays, and the FHIR-IG is the group that meets Wednesdays from 3 to 4. We're always continuously looking for new sponsors and partners. We also published last year data principles. This is the third bullet you see here. We welcome feedback on those. This is around the ethical use of this data to reduce or not further health disparities by the collection of this type of data. We also encourage you to submit data elements for those domains I walked through, especially in the area of interventions. There's not a lot of evidence out there, so it's important to get a sense of health systems or community-based organizations that are capturing this data to submit it. And lastly, we are very active in social media. We have a Twitter handle and a LinkedIn account, and we welcome to partner with organizations on blogs, manuscripts, and any education or dissemination materials. And with that, I conclude with my information, and I welcome you all to send any questions or comments to me directly or through the Gravity Project inbox.